of islet?
Sir, this is not my
No, 1 second. Nimitha, efficacy of diode CPC alone versus combined with intravitreal bevacizumab in neovascular glaucoma management.
So, good afternoon. I'll be talking on efficacy of diode CPC alone versus combined in with intravitreal bevacizumab in NVG management. So, neovascular glaucoma is an advanced disease, and standard treatment includes PRP to reduce retinal ischemia. And diode CPC basically lowers IOP with a success rate of 59 to 81%. And anti-VEGF like intravitreal bevacizumab causes rapid but temporary regression of neovascularization. And on combining anti-VEGF with diode CPC, it may enhance the IOP control and symptom relief. So basically, we are comparing the efficacy of diode CPC versus diode CPC with intravitreal bevacizumab in controlling the intraocular pressure and regression of neovascularization. So this is a retrospective series where NVG patients of case records were studied between the year 2021 to 2025, and all patients with more than 21 millimeter mercury IOP were studied, and exclusion criteria were patients who lost follow-up before 3 months post diode. And based on the records, we had divided the patients in diode CPC alone and diode CPC with Avastin. So informed consent was taken, and based on sorry. So after the superior and inferior quadrants were treated, avoiding 3 o'clock and 9 o'clock position, and the power was 2000 milliwatt and 2000 milliseconds, and the parameters were adjusted using a POC to avoid a POC. Intraoperative documentation and postoperative care also was given with topical steroids, anti-glaucoma medications, oral non-steroidal anti-inflammatory drugs, and carbonic anhydrase inhibitors were also given. And there was after in each follow-up, a comprehensive examination was done, and complications were also assessed. The primary outcome is basically IOP less than 21 or more than 30% IOP reduction from the baseline, regardless of the topical anti-glaucoma medications. And failure was IOP more than 21, not controlled with maximum anti-glaucoma medication. Hypotony related complications, need for additional cyclodestructive procedures, and increase in number of anti-glaucoma medications after 4 weeks. The secondary outcome was the regression of neovascularization, change in BCVA more than 2 lines, and increase in number of anti-glaucoma medication, and the need for acetazolamide use. Statistical analysis were done. So of the 168 patients, 31 patients had lost follow-up, and 137 were included in the study. In that, 92 patients belong to the diode only group, and 45 patients were with diode with intravitreal Avastin, and the mean age was between 64.54 years, and males were more commonly affected, and 47.8% had underwent PRP in the diode group, whereas 24.4% had undergone PRP in diode with Avastin group. So the most common cause in the diode group was CRVO, whereas in the bevacizumab group, it was basically diabetic retinopathy. And there was a decrease in IOP, that is from 45 to 19.6 in the diode only group, whereas from 46 to 25 in the diode plus Avastin group, which is not statistically significant. The success rates were more with the diode only group, and the majority of the patients had poor vision, and there was higher proportion of a higher proportion of non-perception of light patients in the diode with Avastin group. And the mean decrease in the medications were not significant. The regression of neovascularization was more common in the diode with Avastin group. It basically concludes that it's effective in reducing iris neovascularization. Complications were more common with the diode group than with the diode with Avastin group. So in this study, both diode and diode with Avastin, there was significant IOP reduction, but the difference was not statistically significant. And this is consistent with various studies, which shows that anti-VEGF gives only temporary reduction in IOP, and long-term pressure control is basically basically dependent on the ciliary body ablation. This is a study by Fong et al. Here, they had the more IOP reduction seen in the diode group, whereas our study, there was no statistical difference. Regression of NVI was there, and also hypotony was in Fong et al. Study. It was more common in diode group. Ours was not significant. Ehlers et al. And Yazdani et al. Found that bevacizumab enhances neovascular regression and reduce the risk of hypema during CPC procedures. And visual outcomes, there was only 8% patients had in the diode only group retained useful vision. The complications like epithelial defect, hypotony were there seen in our group, and the limitations was it is a retrospective nature study, and also the proper documentation in the medical record for the detailed procedural reports and for the outcome measurements such as post procedural inflammation and pain was not properly documented. There were several patients had defaulted in the follow-up visits. So to conclude, intravitreal bevacizumab appears a useful adjunct to diode CPC in enhancing the neovascular regression and to lower IOP, though long-term vision salvage remains limited.
Thank you. Thank you very much. Can you please go back to the slide? Can we allow her to put the presentation where you showed that 44 cases PRP were done, 11 cases PRP were not done? Yeah.
So this is 44 cases PRP was done in the diode group,
Yeah.
whereas 11 cases PRP was done in the diode plus.
So could this be the reason why the IOP lowering was better in your diode? So what, next slide please, after this. So you see there, I think so you said something about the diode alone group, right?
The IOP lowering was much, the
Better.
success rate was more in the diode only.
Yeah. So why do you think it could have happened, madam? Because why there was so much of disparity? 44 patients had PRP and only 11 patients had PRP in the diode with bevacizumab. Why the PRP was not done in that other group?
Actually, since
we all know that the VEGF originates, and because of the hypoxia itself, it happens. And treating the laser, that's why it has shown very good results with the diode alone group. Whether you had put the anti-VEGF, see, anti-VEGF according to me works only temporary. It has already been shown. It reduces the intra-op bleeding while you are doing these procedures or post procedures. But my only question was why there was so less amount of PRP done in the other group versus this group. When you saw the almost CRVO and DR were almost similar, majority of them had CRVO or DR.
Actually, the number of patients in the diode group and the diode with Avastin.
So if you look at the percentage, that's what I'm telling. It should be apple to apple comparison. So then only you can always try to get the results. If you put one, so that's the one of the drawback, because it was a retrospective. And so did you try to make it prospective from now at least?
Yeah, we are working on it.
Thank you, Dr. Nimitha, for sharing your data. and a good presentation. So my question is, well, there's a lot of data here, a lot of confusion, and as Dr. Srinivas said, 92 and how much was the 45? Yeah, so there is a disparity between and you can't actually compare the groups when it is so much of a disparity. One thing, takeaway, has your practice pattern changed with the data that you have presented here today?
Actually, with the with the after Avastin, within like 15 days, we do the diode. That's it.
So you prefer TSCPC with Avastin, or you would consider
Yeah,
PRP?
if there is a frank NBI, and if you know,
Because your PRP gave a very good result. That's what I understood, right? Yeah. So has it changed the practice pattern? What would you do?
PRP with Avastin, we
Thank you so much.
Thank you, Dr. Nimitha. Hope you will try to do more prospective studies on this and do similar procedures done on the both. That is PRP done in the both, but adding of anti-VEGF, does it have an effect? I think that is just a suggestion.